Hi, I'm Vic Tapson. I'm in pulmonary critical care. I'm at Cedars-Sinai Medical Center out in Los Angeles. Today, I'd like to talk a little bit more about acute pulmonary embolism. So patients that get pulmonary embolism often have certain risk factors, and these risk factors tend to be based on injury to a vein, like a broken leg, broken hip, injured vein, what we call immobility, reduced mobility, that tends to make clots form, or finally something called hypercoagulability. You may have a genetic problem, or certain patients that have certain kinds of cancers may have what we might call thick blood, or a hypercoagulable or thrombophilic state. Those patients may need more prolonged therapy. So patients with acute PE can vary in terms of the risk factors. Sometimes we see patients that are unprovoked. They may get a clot and we can't figure out why in the heck they got it. A long plane flight may put you at risk, but millions of people fly every day and don't get clots. So people that get clot just after a plane flight, you might think to yourself, well, what's going on with this patient? There's something unusual about them, and consider doing some blood tests on patients like that. Rare patients might never recover, but most patients do. And perhaps an older patient with more comorbidities, more underlying heart or lung problems might take longer to recover. Someone with a big pulmonary embolism may take longer to recover. It may take days for people to start feeling better. Generally, within a period of several weeks, people start to feel better, get back to normal. They often feel better in a couple of days, but before they really are getting back to feeling comfortable getting up and around, it may be a few weeks. And there's a syndrome people are talking about based on some research recently called post-PE syndrome, meaning kind of after PE or after pulmonary embolism. They don't feel like they recover quite as quickly. Fatigue, tired, short of breath. And this may be due to persistent clot in the lung, or may be due to something else that may not be known yet. So patients may take a little longer to recover than you'd think. We don't necessarily need to know if a clot's gone. If somebody's symptoms improve and they're feeling better and getting back to normal, we don't necessarily have to rescan them or do other tests to see if the clot's gone. Some patients feel better kind of knowing that. We definitely rescan people if they're still having symptoms. If I see someone in clinic at a month or especially 3 months, they're still short of breath, we'll do another CT scan or lung scan on them to see if that's from residual clot in the lung or if it's from something else, or maybe from a recurrent clot. So while it's important to know, it may seem important to know if the blood clot is gone, the most important thing is there persistence of symptoms. Some patients may progress and get something called chronic thromboembolic pulmonary hypertension, or CTEPH, meaning the clot doesn't go away, scar forms, the pressures in the lung go up because these blood vessels are narrowed and scarred, the heart can't pump the blood through, and they have CTEPH and may need surgery for this. But that's a small percentage. That's 1 to 3%. A few percentage of patients may get something called CTED, chronic thromboembolic disease, where the clot doesn't go away. You see it on the scans, and we're still working through the definitions of CTED, but the bottom line is patients that have persistent clot on their scan without having pulmonary hypertension. So again, the bottom line is you may or may not need to really know if the clot goes away, but you really want the patient to get back to normal. You want to study them, test them, look at their oxygen level, do an echocardiogram, look at their heart. If their symptoms aren't coming back to normal, and of course consider a repeat scan. So treating a pulmonary embolism is variable duration. I mean, if you have a provoked clot, let's suppose you fall and break your hip, you got a really good reason to get a blood clot. You need to be treated at least 3 months with a blood thinner. We often treat people a little bit longer. If they have persisting symptoms, they're not going away quickly, say they have persistent leg swelling from DVT, and their ultrasound shows they've still got some clot in their leg or still got what we call recanalization present, we may treat them longer, we may treat them for 6 months. One of the key things to deciding the length of therapy is, are there persistent risk factors? If you have ongoing cancer, we generally like to continue a blood thinner as long as that active cancer is present. If you have an ongoing risk, if you're a trauma patient and you come in the hospital and you have broken bones, you can't get up out of bed, you can't move, and you get pulmonary embolism, we'll treat you until you're up and around, walking around, whether that's 3 months, 6 months, longer. And then there's a group of patients we call unprovoked. Unprovoked patients generally should be treated what I would call indefinitely, maybe forever. They at least need to be watched very closely, because if you get a blood clot and you can't figure out why someone got it, that means they got it pretty easily, and it means it can happen again. So the duration of therapy really does depend on certain situations. If it's provoked clot, risk factor goes away 3 months generally. If it's unprovoked, persistent risk factors, we continue therapy. When we see a patient back in clinic that's at pulmonary embolism, we have to make decisions whether to do more testing. If they've gone back completely to normal, they're going about their business, their work, play, everything is good, there's no shortness of breath, their oxygen's normal, we often don't do any more testing. There's really not a standard of care for what to do in that setting. You always retest someone or do some tests if they've not gone back to normal. We have a very low threshold to do a VQ scan, which is a very sensitive test, at say 3 months or 6 months, even if someone's gone back to normal, especially if they've had a pretty extensive blood clot burden in their lungs. And if they haven't had any symptoms at all, once they've recovered and everything is doing fine, we'll examine them, talk to them, see what their symptoms are like, check their oxygen level, then decide whether to get a repeat VQ scan or CT scan. The radiation from these tests, like a CT scan, really is much, much lower than it used to be. So these tests are pretty safe. We may repeat an echocardiogram to make sure it's gone back to normal. A lot of patients get an echo test of their heart, an ultrasound of the heart, that is, when they have a PE, to see how bad if their heart's having problems pumping against this clot burden. And if that heart's abnormal, the right ventricle, the right heart's abnormal, we like to make sure that's gone back to normal. So that's another test we'll often repeat when someone comes back to see us. I'm Vic Tapson, and I'm aware that I'm rare.